Hi all, let's talk a bit about case conceptualization. So why do we need some case conceptualization? Well, it's important that we use case conceptualization because it's part of being a scientist practitioner. So what that means is that we're not making clinical judgments based on our intuition or what feels right or what worked for us or what worked for another client. We're actually making clinical decisions based on theory and based on research and using theory and research to inform our clinical decisions. One thing we know about counsellors, along with all other mental health professionals, is that we are vulnerable to cognitive biases or faulty thinking. And one of those ways that plays out is that we use what cognitive theorists call confirmation bias. So that's when you look for examples in a client's story that confirm what you already expect to find. So you may make a decision about a client having an issue with self-esteem, and you listen to their story and only pay attention to the parts that I guess prove or back up your theory about that client. And so having a model or a way of developing a working hypothesis is really important, so we don't fall into the thinking or cognitive traps that every human being falls into, and therefore lead the client down the wrong path. So case conceptualization is one of those ways we can do that. So it's a way of developing a working hypothesis. So it's a working hypothesis in that it could change over time. It's a way of providing a rationale for treatment. So if we were to explain to another person why we chose to approach working with a client in a certain way, we need to be able to use the theory and the research and also what we've observed with the client to form some kind of model as to why we've gone down a certain track. Not just because we like using a certain therapy, but because based on our case conceptualization, it seemed like this was the best way to go. It anchors our thinking. So sometimes a client will come in and tell you a huge story and you just don't know where to start. So by trying to organize the themes and organize what might be going on for the client, it can help you summarize a large amount of information, which can help you then figure out what's the best way forward from here. And some agencies require you to write a written treatment plan. So you'll be doing that every time you start with a new client. Oops. So case conceptualization is formed from the assessment session. So that first session, when you meet a client, you're gathering a lot of the information that will inform your case conceptualization. And it's a way of describing the client's problem, or what's led to those problems, what kind of is maintaining those problems, and what might help those problems as well. So it's collaborative. So we build that with the client, finding out how they see the problem, what's helped, what hasn't helped, what they think is contributing to the problem. So it's not just us making decisions about the client, it's about working collaboratively with the client, using our nice open questions to get a sense of how they experience the problem. It's based on observed or reported data, so it's not just hunches, it's also observing behaviours or observing statements that the client's saying. or reported data about life events or other symptoms that they might be experiencing. So things that we can very specifically write down in a case conceptualisation, such as symptoms of depression, so low mood, lack of energy, frequent teariness, a withdrawal from social relationships. So those are things that can be reported to you or observed. Integrated, so we need to look at all the areas of someone's life and integrate all of those areas into themes that might be connected. It also requires you to make educated guesses regarding what could be going on underneath, certain problems. So we might be looking at things like grief or trauma, for example, when we're looking at a collection of symptoms or problems that the client's having. So educated guess, again, refers to using the research and the theory to make those guesses. It's not just about a hunch. And it also provides a roadmap to guide your future work. So it gives you a sense of, so this is how we're going to approach this. And then you can assess after a little bit of time how things are going. Is this working? You can use outcome scales to measure whether something's working or not. And you can also get the client's feedback as whether they think it's helping. Sometimes we need to review case conceptualization given new information that comes to light. So the way that we use a case conceptualization or put it into place really does depend on which theory or model we subscribe to. So person-centered, behaviour therapy, narrative therapy all have a very different way of implementing case conceptualization. And the New Croak book really goes through that in quite a bit of detail as to how you might conceptualize a case using cognitive therapy versus person-centered therapy versus psychodynamic therapy. So have a look through and look at the examples in the book there. So some of the clues that we're looking at that can help us conceptualize a client's problems are disturbing or distressing life experiences, relationship issues, ineffective personal interactions, so interpersonal kind of communication problems, connections between something that's happening now and traumatic incidents. So intrapsychic, so that's things that happen internally, such as feelings of shame or feelings of unworthiness or feelings of fear of things going wrong or being vulnerable. Maladaptive functioning, so that's where for example, a client will engage in a behaviour that enables them to feel less distress in the moment, but over time it's harmful or not helpful. So that could be clients who refuse to feel their emotions, so they might push them down, or they might engage in behaviours like drinking, for example, to distract themselves from those feelings, or they might avoid getting into close relationships. Environmental challenges, so things like homelessness or domestic violence and other things that are going on in the person's immediate surroundings. What's worked for the client? So that's another really key area. So you might, if they've already seen a counsellor before, you want to find out, so what was helpful about that, and what wasn't helpful. And we need to do that in a way that is very respectful to the other professionals. So we don't want to ever say, oh, well, you know, that doesn't sound like it was very useful. We need to be aware that the story that the client's giving us is certainly one-sided. And while they didn't feel that it was helpful, maybe it was the particular situation the client was in at the time. So we need to make sure that we take on board what worked, what didn't, but not make any judgments about other professionals. So it goes back to the ethics lecture. You know, we don't want to give clients the impression that we are a far superior counsellor to another counsellor. Things that haven't worked. So, for example, you might have some clients who find the cognitive approach really doesn't work for them. They're much more into the experiential, and so perhaps schema therapy or acceptance and commitment therapy might be a better fit for them. So we can use all those things as clues to develop our formulation. We also want to make inferences around things that are contributing to the problem. So, and this is, you know, when you're looking at the 4 Ps that I'll get to you in a minute, this is really what's maintaining the problem, but also what's underlying the problem. So what's the predisposing, I suppose, issues for the client, but also what's maintaining it. So core beliefs could be predisposing, but also they could be maintaining a problem. So defense mechanisms lacking in skills, of maybe lacking in communication skills, lacking in ability to deal with anger, lacking in ability to be assertive, those kinds of skills. Poor social support could be also another area. We want to make inferences about a client's strengths. They might not necessarily share these directly, but we want to take examples that they've given us and see the strengths in the way that they've responded to those. So we need to draw them out and put them into our case conceptualisation, because that really that helps us. It helps inform us of what we can build on there in terms of protective factors. And what might help. So we can also get examples, you know, when the client is sharing when the problem hasn't been so bad, and, you know, what's helped in the past, and, you know, what makes them feel better and what works and all that kind of thing. So it's not just for us to decide what might help, it's the clues that the client's giving us too. So in the textbook, this is how case conceptualisation is described. It's observing, assessing and measuring. So that's in our initial session. We'll observe, we'll gather information, but we'll also assess and measure how things are going over time. And we can use those various different scales to do that. And you'll learn more about how to assess and measure outcomes in professional practice in second year. So we're using our observations to find patterns and themes, and we're using these patterns and themes to interpret, explain or make clinical judgments. So it's the clinician's understanding of the client's needs and the clinician's ideas of how to serve the client, which drives case conceptualisation. There's a few views of case conceptualisation. Another one is by Cozzolino, who describes it as a description of presenting problems, symptoms and possible diagnosis. So a general term that describes the problem, such as depression or social isolation, or, you know, problems with adjusting. A theory or theories accounting for how and why the problems have risen and evolved over time. So that's drawing on the published theories on why these problems might have risen and evolved over time, but also taking what the client's sharing with you to develop that theory. And a general description of how these problems can be addressed or overcome. And we can organise this information a number of ways. You can use the inverted pyramid method that's referred to in your textbook. It is a more complicated way of organising information, and sometimes new counsellors can struggle with this. So that's why we use the 4 Ps approach, which is basically looking at predisposing, perpetuating, hang on a second, we'll go forward, protective and precipitating factors. So there are many ways to organise information. This is the way that we use in this course because it's a really clear and easy to remember way of organising information, but there's lots of different ways you can do it. Sometimes you're given a particular case conceptualisation form to fill in with the agency that you're working with, and so you need to adjust according to that. Right, so first of all, we need to look at the problem and using the 4 Ps. So we look at predisposing. So what makes the person more vulnerable to developing this problem? Then precipitating, what has triggered the problem? Perpetuating, what keeps the problem going? And protective factors. What strengths does a client have that has stopped the problem from getting worse, or that they can access to help them overcome the problem? Sometimes you'll see a reference to the 5 Ps, and that just refers to, it's using an extra P to refer to the presenting factors. All right, so this is just another explanation of the 4 Ps. So not everyone does it the same way. So some theoretical orientations see the assessment as being fluid. So you're always assessing, you're always adjusting as a client moves along in their therapy or more information is revealed as that trust develops in the relationship. And New Krug talks about the need to review and revise our assessment. So it's important that we don't become rigid to our assessment. And again, using that confirmation bias by only paying attention to something that proves our assessment or case conceptualisation. So we need to stay open to the need to revise and review and to change along the way. So there's no right way of developing a case conceptualisation, but the most important thing is that we use the theory to inform the case conceptualisations. So it's not an ad hoc approach. It's a scientific approach that collects a number of the themes and a number of the issues in the person's life, applies theory and develops some kind of plan of going ahead. So it's important that we don't let assessment and conceptualisation distract you from attending to the client's needs as a human being. So assessment of what's happening shouldn't lead to categorising the person. So while we might sometimes use a label to describe their symptoms or their experience, we mustn't lose sight of their individuality or label them or stereotype them. So, you know, for example, you know, an eating disordered person or, you know, someone with bipolar, we want to make sure that we see them more than their label, that their experience is very different to the next person with bipolar. And we want to keep an eye on the personal and individual experience of that problem so we can tailor our treatment to the individual. And this is just a nice quote that I like. And it's about learning to be okay with uncertainty. And I think one of the amazing things about counselling is that it's a creative endeavour, in that we have to get to know each individual client and figure out a way forward based on the theory, but also based on our knowledge of the individual. And that can create some uncertainty, because there's never a black and white in counselling. And so some of us need to work on our ability to sit with not knowing the way forward. And when we don't know the way forward, the best thing to do is to really focus on developing that therapeutic relationship so we can step into the client's world and get a better idea of what could help based on how they see their experience. Okay, so in the tutorial, we're going to look at a video that you've already watched before, but this time you're going to be looking at it through a case conceptualization framework, and you're going to be trying to ascertain the 4 Ps and develop some kind of idea of what could help the client. Now, some of you who haven't done theoretical approaches yet, you know, just use what knowledge you already have. But if you have done theoretical approaches and the approaches to mental health course, then use those, that learning, and bring that into this case conceptualization. All right, thanks very much, and I'll see you all soon.